Is it working? Okay, good. Good afternoon, everybody. I'm honored and very pleased to be chairing this session with the four young ladies who are presenting very interesting papers and all under the theme of towards evidence-informed policy making in the health sector. So we are going to enjoy four very rich presentations that go around the topic from different angles. We will see elements of health policy. We will see elements of health system strengthening. We will see elements of service provision. We will see elements of innovation in health, and all are quite interesting and quite enriching and complementary to one another. So let me suggest first that we're going to present all the four papers because we are short in time. Unfortunately, we took some more time in the lunchtime, so to abide by the closure, which will be 5:30, hopefully not too late afterwards. So we'll be presenting the four papers first, 10 minutes per presentation. And if any one of you wants to take notes or questions or so, please record it so that after the end of the presentations, we will open the discussions. Let me start with the order as per the agenda. I'm pleased to introduce Ms. Aya Ahmed Shakir. Aya Ahmed has a bachelor degree from Cairo University in physiotherapy, and she is going to present us a very interesting topic about exploring the use of telemedicine during COVID-19 pandemic, healthcare perspectives, healthcare professionals' perspective in Egypt. And that was, as far as I understand, this is her graduation project for the master degree, professional master degree in health economics from the Faculty of Economics and Political Sciences, Cairo University, right? Okay. And then we will be listening to another interesting paper done by our colleague, Eugene or Jenny, whichever you find easier to say. Yes, and our colleague is presenting a paper on design thinking, which is a quite interesting and new topic in healthcare, enhancing access and quality of breast care in Egypt. Ms. Eugene works in the Department of Public Policy and Administration at the AUC. She is Greek by origin, and we are very pleased to have her with us. And then we'll be listening to Ms. Marwa Farag from the School of Public Health. Yes.
School of Economics.
Yes.
Public Policy and Public Administration.
Okay.
Public Administration and
Yes, Doha University, right? Yeah. Okay, great. 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 And Marwa will be presenting to us an interesting study on the Qatar mental health in action, exploring practical perspective, patient's perspective, sorry, on access and care services. And then last but not least, we'll be concluding with our colleague, Minnatullah El-Bahiri. She'll be presenting to us a paper called Determinants of Physicians' brain drain in Egypt, which is a quite hot and very important topic, like other topics, of course. And Dr. Minnatullah is a medical doctor. Besides, she has also a master degree in health economics and master degree in public policy. And she's working with World Bank as a health economics consultant. So we have a diverse group of people. We'll be enjoying very much listening to them. We'll start with Aya. And if we may ask you to focus on 10 minutes only, if possible. I know it's quite challenging, so that we can give time, for elaboration afterwards. Please. Yes, this is yours.
Thank you. Enter. Thank you, Dr. Magdi, for introduction. Good afternoon, everyone. I know it's after lunch and you are full, but I hope I finish in 10 minutes. I am Ahmed Shaker, physiotherapist and healthcare quality specialist. This is my second time to be in AMEPPA. I would been here in the last year, so I'm so grateful. We'll start with okay. This was my thesis in health economics, like Dr. Magdi said, exploring the use of telemedicine during COVID-19 pandemic, healthcare professional perspective in Egypt. Karim is my colleague. He was with me in this thesis. Our outlines for today is terminology. Some terminology we must be aware of it. Definition of telemedicine, objectives of my study, methodology, and result. And we will finish with some recommendations. Okay, about terminology, many of us heard about telemedicine, telehealth, AI in healthcare, but we are getting confused. Even decision makers got confused about this terminology. The first term is e-health, which is equal to digital health. It's delivering healthcare services, surveillance, or education through telecommunication devices or digitalization. Many countries nowadays going for digitalization, and also healthcare is a sector going for digitalization. Part of the e-health or digital health is telehealth, which is contain telemedicine, telerehabilitation, telenursery, and every tele. Part of it is mHealth, which is mobile health. It's part of telehealth using mobile devices for telehealth. In this point, we know telecommunication agencies started to transform from telecommunication to TICO, like اتصالات forming from اتصالات to E-end. And this is the future of telehealth. It's going to be a TICO. It's not about telecommunication devices only. The fourth term with us is AI, artificial intelligence in healthcare, which is computer and machine processing to simulate human intelligence and perform complex automated tasks in healthcare. AI could be combined by telemedicine and serving patient in distance. But e-health or digital health is using digitalization devices only by human factor, like starting from e-medical record, ending with surgery on distance. Okay. About telemedicine, it's alternative method of medicine delivering healthcare through a tool of telecommunication devices. It's not a recent phenomenon. It started back in the last century in 60s by NASA monitoring and evaluation physiological changes and vital signs of astronauts in the space. But many authors thought it started before that for radio for delivering healthcare education and treatment through radio signals. So it's in the past, يعني. Types of telemedicine, store and forward is the first type of telemedicine. All of us use it, store lab result or radiological image and send it to doctors. It's part of telemedicine. Second one is remote patient monitoring, like devices used in chronic diseases for diabetes or hypertension, and alerted when extreme results come up for the patient. Real-time interactive services or live conversation with doctor to doctor or doctor to patient. Our objectives for this study was exploring extent and method of telemedicine modalities used during the time of pandemic in Egypt. We did this study in 2022. So we are assessment of healthcare professional point about role of telemedicine in comparison to standard care in this era between 2020 to 2022. And also we will discuss importance and the drawbacks of telemedicine. About methodology was a cross-sectional observational descriptive study. Sample was healthcare professional, and selection criteria was convenience and a self-administrated questionnaire sent to doctors and they reply to it. Location of many participants was Cairo, Giza, and Alexandria, so it's specific to those governorate. Okay. Results of this research showed many participants used, almost 90% of participants used telemedicine in this era. Many of them was in private healthcare facility, which is indicator for infrastructure of public healthcare facility. We will talk about it. And about the platform used for telemedicine was WhatsApp. WhatsApp is a very promising application. Now we have Meta AI in WhatsApp. We can ask AI in WhatsApp. And in Brazil and India, they have a payment methods. So it's no need for third-party company or third-party application for pay in WhatsApp. So WhatsApp is going to make a big development in the future. Okay, about importance, most of results said health education for chronic patient is very important using telemedicine. We don't have to have a patient in the hospital. You can give them the health education or health promotion to the public also through telemedicine solutions. And also for palliative care, like in oncology patients. Second one was equity in care. Equity in care is very famous topic nowadays. Also economic impact. Economics is a science of scarcity. We have limited money for sure. We have limited doctors. We don't have to multiple coverage of doctor in every location. We have limited resources in everything. So we can have a privilege of telemedicine, which is sustainable development. We will limited as a carbon footprints for emission. So we can have a favor for sustainability in telemedicine, and also efficient modality to referral between level of care, primary, secondary, and tertiary. And I think all of us now, we have an importance of telemedicine. Can anyone say anything? جودي مثلا؟ يعني Yes. Very true. Now here in Egypt we have health insurance coverage. It's promising program for providing telemedicine in rural area, like Khalid said. About importance. Okay.
Excuse me, if we can postpone the questions till end of the and you have only 2 minutes.
Okay. About importance, about the differentiation between telemedicine and and the standard care, they don't agree. It helped them for reaching final diagnosis, and I think it's a lack of training for telemedicine solution. Doctors didn't, they didn't train to use telemedicine in college, so it's a new thing to them. And the other thing was supported, it's a supported tool for plan of implementation of plan of treatment. Okay, about challenges, we will go with most drawbacks in telemedicine was misunderstanding and patient overuse of communication tools. I think both are related, and I think if we did this study in the physical examination or face-to-face, we will come up with the same problem of misunderstanding. And I think it's not the patient problem, it's doctors. We need training for communication skills. We have in Arab world, we have a privilege for being a doctor. We don't train for communication skills for understanding the patient language, not your language as a doctor. And future of use of telemedicine is very prominent. They agree that they will be they will use telemedicine in the future. In conclusion, like we said, it's an alternative tool, but they need a training for reaching final diagnosis, and it's filling the gap in global healthcare, providing affordable and accessible healthcare in remote regions worldwide. Our recommendation for this presentation is we need to overcome those drawbacks: culture, technology literacy, infrastructure in Egypt, payment method, and official platform for telemedicine. And we do that, we need research. We need research to see the impact of telemedicine for the past 2 years, and we need the patient perspective to be monitored, and we need also a planning fail to plan is planning to fail. We must plan for the future. We must plan by training medical students for many skills, not also academic skills. We need social skills to deal with technology and deal with the future. And the government have a strategy, digital health strategy. It's a draft of it. We had 3 consultation sessions to frame this strategy, and this is the draft. I can send it to anyone if you need it. And we have a law for telemedicine now in the Egyptian parliament. It's under preparation, and we have a national hospital standards, Gahar standard, national accreditation hospital standard. We have now a telemedicine standard. So every hospital providing telemedicine solution must have a policy for confidentiality and for privacy of the patient and how they use telemedicine. To summarize, we discussed the importance and challenge and my research result. I hope you understand it, and we thank you, Dr. Magdi.
Thank you, Shaya. Yeah, thank you so much. I know you were struggling with time, no, but you did very well. I think your paper is clear to us. You tackled it from different angles. It's multidimensional, multidisciplinary approach, and it's definitely part of the future. Now we will move into another dimension of new innovations in health, and Miss Jenny Dr. Jenny actually will present to us a very interesting topic. Yes. Okay. So that, yeah, sure.
So you can use the screen.
Yeah, sure. Yeah. No, that's okay.
Am I okay here?
Yeah, please, Dr. Jenny, please go ahead.
Thank you for the invitation. It's a great pleasure to see that AUC is incorporating topics about healthcare, because I've not in AUC for many years, but for the last 2 years I've been quite nagging about it, because I think it's a quite important topic to be included in the studies, and it's a footprint for the future. So today I'm going to talk about design thinking in healthcare, enhancing access and quality of breast care in Egypt. Briefly, I will start with some data so that we have a common understanding about the numbers related to breast care, breast cancer, which is the leading cause of death across the world, together with cardiovascular disease. The numbers are striking, and I will start with the financials, which are really important and play a role and have an impact in any healthcare systems. Unfortunately, the data are coming from the US and the UK, because the rest of the world are not good with summing up the financials. So in the US, the cost of treating breast cancer goes up to almost $30 billion. It was 29 in 2022. And this constitutes 14% of total cancer treatment costs. It's a big number. In the UK, the same number goes to $3.67 billion, and it's expected to increase by 40% in the next 10 years. The numbers are astonishing, and we have to consider that more than 500,000 women die every year because of breast cancer. Facts from Egypt. Egypt has been doing quite well when it comes to screening. It ran a national registry from 2008 to 2011. Most of the Middle Eastern countries do not have such a registry, and it's good data that the country collected. Breast cancer comprised 32%, according to studies back in 2014. But it goes up to 38% in 2021, with 11% mortality rate. The reason of the increase is because the number of screening has increased. So it's not about treatment, it's that the country improved in the number of women that were screened for breast cancer. So the country did well. The problem rests in the death rate, which stays quite high. The reason behind the high mortality rate of breast cancer is 40% of the population has only access to public care. So it's a combination of things. Is how many people go for screening, how many people stick to a treatment program that is initiated and advised by the healthcare institution that they are following. And this increases the number of death rate related to breast cancer. 60% of the population is served by non-profit organizations because, as I said earlier, only 40% have access to public care, and only a small fraction goes to private centers and those who have the financial capacity to afford for private care, which is a very small percentage of the Egyptian population. There are government programs that Egypt has put forward. The Women Health Outreach Program from 2007, which they scanned 20,000 women across 3 governorates. That's how they started. The Universal Health Insurance Law launched in 2018 that aims to decrease 15% non-communicable diseases. Breast cancer is included in this group. And the 100 Million Healthy Lives program, which was launched in 2019, and it was a sweeping program because 8.5 million women were screened from 2019 to 2020. This explains the increase in the breast cancer identified because of this program and the big number of women who were screened. So the problem is that despite the improvements in treatment effectiveness, prevention and early detection rates remain low. There is lack of screening awareness, but especially in Egypt, limited access to care. Egyptian women more and more know what they need to do for screening their breasts to identify cancer early, but the country has problems when it comes to accessing care because of transportation problems, because of other responsibilities that we will see further down. This increases the high, this justifies, not justifies, but this explains the high fatality rates and that are expected 46,000 women by 2050 to die out of breast cancer. Now, the questions in this study is how design thinking, which I will explain shortly, can be applied with within healthcare organizations in order to foster innovation and empathy, because we see breast cancer like it belongs to somebody else. So the woman as a patient has to be in the center, and there has to be empathy associated with the treatment, with the early diagnosis, so as to have early prevention or early treatment. How to ensure stakeholder involvement and not groups to work in silo. How to ensure sustainability and effective management solution for early breast cancer prevention, and how design thinking can, as I said, enhance early screening, awareness, accessibility, and efficient processes for breast care. Now, what is design thinking? Design thinking was initiated as an idea in the business field, and it was also applied in the construction industry. That's how it was initiated. There are very limited data in the healthcare, but it's increasingly taking a footstep into the healthcare because it's a human-centered approach which demands collaboration among diverse teams and rapid prototyping and bring solutions as early as possible. And considering how things are evolving and how things are progressing, design thinking is becoming more of a requirement in the healthcare field compared to traditional methods of addressing chronic diseases like breast cancer. So the key steps involved is understanding the problem and the affected individuals, generate ideas to address the specific problem, testing those ideas to identify what's the most suitable solution, and implementation. Now, when we say understanding the problem, mainly is understanding the female patient. The continuum of breast care, it's not a straight line, and it's not a straightforward pathway, because it starts from self-assessment. When the woman finds something on her breast, then she will follow for a clinical evaluation. If that is not enough, then she will be sent for screening. There are several screening modalities, several screening technologies, very confusing for the patient. She might be asked to come again and again because she needs to be screened in different stages, depending on the results and the equivocal findings that may be related. Reading a screening image of the breast is the most demanding task that the radiologist is called to do. and you have MRIs, you have mammographies, we have PET systems, you have a lot of technologies associated with it. And after cancer is identified and you reach the stage of diagnosis, then you have to follow the right treatment and the post-treatment follow-up for recurrence and everything. So it's a long way, and as I said, it's not a straightforward process which causes anxiety both for the physician and the patient. There are many stakeholders involved. It's not only the medical professionals, but also it's the administrative support, because the patient has to book appointments, come and go from distant places. Financial entities, because the cost of treatment is very high when it comes to breast cancer treatment. Family and friends are involved and have to be supportive. And then when there is socioeconomic problems, things are getting worse and more difficult. And support services like accommodation, like transportation, for example, if she comes for chemotherapy, radiotherapy, and she's coming from distant areas, where will she stay, where the family will stay, who will take care of the children, etc. So the study conducted was a qualitative descriptive study that employed semi-structured interviews to examine collaboration among physicians, multidisciplinary teams, how the decisions were patient-centered, aspects of communications and reach-out activities, increased awareness and understanding, sustainability of breast cancer screening habits. And the settings were non-profit organization, Bahia, for those of you who live in Egypt already know, and 2 public research and teaching institutions affiliated with the University Faculty of Medicine. One was Kasser Alaini and the other one was Cairo Cancer Institute. Participants were physicians, but also information and technology experts and marketing and administrative people. So the findings. More or less all public and the non-profit organizations had different working hours within their day. None of the physicians, though, complained that they had work overload. They were more or less happy through the interviews, at least so far, with the work that they have been doing. The positive findings that all centers examined reported that most women in Egypt have good knowledge and understanding of the importance of breast screening. So they don't have to start from scratch creating awareness like other neighboring countries like Libya, for example. Success stories relate to awareness campaigns that have taken place, as we saw, through the programs supported by the government, the social media that are doing a good job, mobile vans with mammography units that screen many women across Egypt, south to north, east to west, and the work of volunteers. Now, the hiccups. Issues identified. About 20% of the scheduled patients never show up, and that's the main problem of the study. They never show up either for treatment or for secondary screening. They reach a point that they don't come back. Many women couldn't make it to treatment because they were the breadwinners. And according to Campus, about 3.3 families in Egypt are supported only by women. So they say, you know, if I come back, who is going to support the family back home? Or it's not easy for me to commute from Aswan to Cairo, etc. Demographic and socioeconomic information collected is not utilized to indicate the best approaches. So what was revealed by the study is that the socioeconomic information, the demographics information is collected by the call center or by the registrar who introduces the patient to the hospital, but it stays there. Physicians don't have access or do not see this information. So it's information collected but not utilized. That's mainly the problem. MDTs do not have...
Sorry to interrupt you, but we have to enhance because we are short on time.
I'm finishing. Thank you. Thank
you.
MDTs do not have access to these demographics, and they seem to follow only the guidelines from NCCN without precision medicine applied. So the idea that came out of this was that the group suggested that they could develop an AI program that would not tell them which screening process is the right thing or not, but feed it in with demographic and demographic information about the patient, and then direct the patient according to age, lifestyle, family constraints, etc., which is the most suitable a treatment to follow or screening method to follow. So this AI solution would illustrate a kind of precision medicine, a personalized solution for more patients and for more women to have access to healthcare. Because as I was saying earlier, the problem was that the 20% of the people never show up again, and the number could be higher in other public institutions. So according to design thinking, these are the steps that could be followed in an AI platform development for strategic management of breast care. Am I on time?
Thank you so much. Excellent, Yani. It's a very interesting topic. Actually, the innovations in health is always, a field that is very inspiring and allows for a lot of follow-up researches. And I won't be surprised if you go into a second phase of your study to see how this is going on the ground. Yani. Great. Now we move to our colleague, Miss Marwa. She's going to present the third case. Please do.
هاي أنا اسمي مروة فرج وأنا أصلا مصرية بس ما اشتغلتش في مصر من 2003 وكنت بشتغل في مصر في 2003 في مشروع اسمه إصلاح القطاع الصحي كان health sector reform program ومعرفش حد يفتكره ولا لا
أيام دكتور إسماعيل سلام I suppose.
أيوة كنت بشتغل مع دكتور إسماعيل سلام والله you looked familiar بس من وقتها أنا في كندا وبعدين وفي أمريكا وبعدين في الآخر في قطر بس حبيت أقول يعني إن أنا مصرية ومبسوطة جدا إن أنا أول مرة يعني أرجع أشتغل أعمل حاجة في مصر من ساعة لما مشيت البرزنتيشن بتاعي هي فين؟ So البرزنتيشن بتاعتي هي collaboration between me and my student وهي على basically السؤال هو قطر بلد غني جدا وليه هو ما أتكلم بالإنجليزي أحسن؟ Sorry. I got so excited because I'm back. So it's essentially about healthcare access in Qatar. Qatar is a very rich country, and at the same time, when it comes to mental health and access to mental health services, we notice that there are issues. So my presentation follows like the traditional outline, introduction, study setting, the method, the results, the discussion, and the conclusion. Reason I keep going back and forth to my computer is because I added some slides last minute. But basically, we want to know who does mental health issues affect everyone, pretty much. So progress, mental health and mental health advocacy, huge progress globally. In terms of addressing mental health barriers, mental health issues, it has to be done within the context, the specific context where it happens, where there are barriers to access. So that was our questions. Essentially, what are the barriers to access to mental health services in Qatar? What I had written here is, I don't want to depress you, but the World Health Organization expects that by 2030, depression will have become the largest single healthcare burden, costing 7 trillion globally. So depression is going to be the biggest economic burden in terms of health burden, economic health burden by 2030. This is lost productivity. This is healthcare costs, and some people who die. Of course, when we lose someone, we lose a lot of money also. So the World Health Organization predicts that depression is going to be the biggest burden. Okay. I stick with this now. The study setting, of course, I want to tell you a little bit about Qatar. $66,000 per year per capita is a very rich country, is a very small country, 3 million people almost now. The local population is only 11%. So it's a big, rich country, which a young population, as you can see, most people between 15 and 65. So that's the context of the study. The healthcare system is actually very good. It functions very well. It's mostly publicly financed. It's very well funded, and it's publicly financed. So we don't have a lot of financial barriers to access like we have here. Mental health in Qatar, it's not that it has been neglected. There's been a lot of policies focused on improving mental health and mental health access in Qatar, multiple strategies, multiple laws, but we still see a problem. And just to tell you a statistic, for example, from neighboring Saudi Arabia, 80% of people with severe mental health care issues, they don't even seek care. So there is a bigger issue of mental health and mental health. And I think a quantitative study just asking questions about like, what are the barriers to mental health is not gonna do anything to deepen our understanding of what the problems are. So this is, so I've always been a quantitative researcher, and I had a midlife crisis, no, mid-career crisis, and I started doing more and more qualitative research. And this is like maybe my second publication that uses qualitative research. So I have learned as and I did it with my student, of course, who did the interviews. So our study is in an uses an interpretive phenomenological approach, which is essentially trying to find out about the lived experience from the perspective of the people who go through the experience. In this case, people who use mental health services in Qatar. We're both female, we both speak Arabic, but we have very different backgrounds. The theoretical framework we used to design the interview questions was the health belief model, and it was an interview guide, open-ended questions. Each interview lasted 2 hours. That's the health belief model. I'm not going to go through it because I know I'm really conscious of time, but we used it to design. I'm good with time. I'm rushing. I saw what happened. So the data analysis, of course, thematic data analysis, we ensured confirmability. We did the analysis. I want to go to the results. The results are that there are multiple layers of barriers. Socioeconomic culture barriers were the biggest. So we have to realize that it's not always financial barriers, especially when it comes to mental health. So social cultural barriers, we found that there are health system barriers, surprisingly, and there are barriers that lie kind of in the middle. The social culture barriers, I'll go through them. I thought this looks like barrier, but I'm not sure if it's the right image. But this is some of the quotes, which I found is like the real essence of qualitative research, is to hear the voices of the people we interview. So limited mental health awareness. So Rana, for example, said someone with a mental health problem won't go to the doctor because he doesn't know that he has a problem. For example, Amal, she said, when I had a nervous breakdown, I realized I needed to go to the doctor. So no awareness of what mental health. And Ahmed said, oh, he had bipolar disorder, which is very serious. But he said, you know, I thought I was normal. Everybody has bad days and good days. Social stigma. So mental health literacy, meaning I don't know anything about this. Social stigma is what people think of you because you have a mental illness. So this quote by Mariam is really what struck me really hard, which is, she said, I was diagnosed with cancer. Everyone was kind and sympathetic. I cannot compare cancer with depression, but I do put them on the same level. But cancer for me did not affect me to the same degree. It affected me physically, my appearance, my hair falling. But from my family, is how she was treated by her family is what made her sad. It's not like depression. So depression was, she suffered more with depression than with cancer, so because of the social stigma. Self-stigma is how they feel about themselves. The first time I went to the doctor, she was at the university, she said, I felt disgraceful, I felt shame. And the second time that I felt shame, it was like a walk of shame. So this idea that when we have mental illness, we think like something is wrong with us and we feel very ashamed, and there's social stigma and there is little awareness. Traditional gender roles affected how they, acted as a social barrier. For women, they told them it's their hormones. For men, they told them men shouldn't be having feelings. So for both, they were feeling like, you know, it's not consistent with my image about like a man or a woman. So for both, it was a problem. This is something I didn't know, but they also thought that risks to marriage and career prospects. If somebody finds out, you know, I will never get married, I'll never find a job, and you can see the codes. So these are like the sociocultural barriers. So it's like awareness, stigma, and risks. And then when we looked at the health system barriers, and these are perceived, I have to admit, they said the first, they had the people who had past negative experiences, they were like, you know, especially Emma said, treatment exists, but basically doctors just want to prescribe drugs, they don't want to talk. So that also affects your likelihood to want to go back to the doctor. You talked about empathy and the need for empathy in healthcare. So some of the people that were interviewed said, you feel like they don't care, like they don't want to help, like they don't want to talk. That also affects your likelihood and wanting to go back. There were some positive experiences, so it wasn't all bad. Some people said it was a great experience. Actually, this person, I think, was from Egypt. No, she was from she was from Egypt, but she was living in Qatar, and she thought it was a good experience. All of the people we interviewed thought navigating the health system was a big issue, so they didn't know where to go. So, for example, Munira, for approximately 1 year, I did not miss any single appointment. But one day I didn't go, and no one called me, and I didn't know where to go next. So, this idea of navigating health systems it's really important to know where to go and the referrals. So that was also a problem. Long wait times was a problem. Some people commented on the depressing mental health care facilities. Rana said it was overcrowded, hot, too dark. The place was not good. The doctors were disorganized. The hospital needed maintenance. People go there and leave. They do not even get to the reception desk. They immediately leave. Like it was okay. And this is very important. Intersection barriers. What we found is that at the intersection of socioculture and health system barriers, the problem is patients in Qatar were caught between a rock and a hard place. Basically what they said, if we go to foreign doctors, we can't relate. Especially for women or for men, the culture is very different, and they try and it doesn't work, and there's a translator. But also, what really was striking for me is when they talked with Arab, as they say, Arab healthcare workers. The problem is that they will always talk about religion, and they would tell, like everybody said, they will tell them to go pray. So they say when they do that, صح? Yeah, but the problem. Read some Quran. There's nothing again. I mean, I'm not like, I don't think there is anything wrong with telling people to be more spiritual or to connect with your spiritual side. But the problem is that when they did that, they made people feel not only bad but guilty.
And unreligious.
It add insult, and this was, so they were like, where do we go? If we go to the foreigners, they tell us they can't relate. And so there is, okay, so just to say, based on this, we made some policy recommendations. There's discussion, conclusions, and we talked about like really increasing mental health literacy, looking at ways to address stigma, and they had a lot of input how to do this. And they talked about like, especially government investment in health. Like in Qatar, only 2% of the budget goes to mental health, while in other comparable rich countries, 5% goes to mental health. So there is a room to improve investment in mental health. And there is, I think, following this study, there should be quantitative studies, because I can tell you about in depth what the issues look like, but I can't tell you the extent. I don't know of all Arab or all people who speak Arabic who are mental health professionals in Qatar tell people, go pray or read Quran. I don't know if all the, like we need to understand the extent of these issues. And so I'm happy we did that. And I think we need a quantitative study to really document the extent and have a more solid basis for making policy recommendations. So sorry.
Oh, thank you very much. Yeah, excellent. Actually, you touched on a very sensitive and very important issue, and unfortunately, it's underestimated. Mental health is becoming one of the global health issues now, and it's increasing. So what you're saying is important, particularly in countries which have conservative cultures like the Arab region. So what you're tackling is good. And the policy recommendations, I know that you were short in time to present them, but in the paper, actually, you elaborated in a very nice way. Thank you so much. Now, last but not least, Dr. Minnatullah. She will talk about something that is cross-cutting to all what you've listened to so far, which is about human resources for health. A very hot topic and very important. Thank you.
So, hello everyone. My name is Minna Al-Bahiri. Excuse me for my voice. I just recovered from a bad flu, but the cough is still persistent. So, apologies for that. Um, so, yeah. So, my topic, I'm studying the determinants of physicians' brain drain in Egypt. Let me first give you an idea of what's going on globally. So there is a global deficit of 17.6 million healthcare workers with a forecasted deficit of 13.6 million health workers in the low and middle income countries. There's an increasing demand for healthcare workers in developed high income countries. And there is a huge discrepancy in the working conditions between the high income countries and low middle income countries, which gives room for the brain drain phenomena. What is brain drain? Brain drain, it refers to the migration of countries well-educated and skilled individuals and professionals, where the migration usually happens from developing countries to developed countries. While all skilled professionals usually migrate, usually it's higher with physicians, engineers, and scientists. Egypt is a low middle income Arab country, Arab African country. We have 27 medical schools, out of which we usually graduate 10,000 to 12,000 physicians annually. Yet we still have a problem. Egypt has been suffering from shortage of physicians. Calculations in 2016 showed that a physician density of one physician per more than 2,000 patients or people, while the global average is 1.75 per 1,000. Egypt is #1 Arab exporter of physicians to the UK and Australia. As of 2020, Egyptian Medical Syndicate has more than 212,000 physicians who were registered as active members, and this number is expected to cover 110 million people. Think about it and think how deficient this is. 56% of all registered physicians are employed overseas. So 56% of this number are employed overseas. So this shows you how a huge problem it is. And 15% are exclusively working in the private sector. So you make the calculation and you think how many physicians are working in the public sector. My research problem here is there is a growing health needs and population. We have decreasing number of physicians working in the public sector, which creates a human resources for health crisis, inequality, poor health outcomes, and failure of the universal health insurance system that we're implementing at the moment. What will happen if you go to receive your healthcare service, but you don't find a doctor there who will give you the service? So my research question, how and why does physicians' brain drain occur in Egypt? And in order to answer this question, I targeted 3 sub-questions. What are the factors that repel or push the physicians out of Egypt? And what are the factors that attract or pull the Egyptian physicians to other high-income countries, and what are the facilitators or barriers experienced by the Egyptian physicians who migrate? So to give you an idea, in order to carry out my research, I did my conceptual framework around the factors that affect decisions of physicians to migrate. So there are the push factors, factors that push the physicians out of Egypt. And these factors are financial, professional, and general country context factors. On the other hand, there are factors that pull physicians to high-income countries. And again, these factors are financial, professional, and country context factors. During the decision-making process and the migration process, physicians usually encounter facilitators, someone who gives them extra information or a website, or barriers, some challenges that put some, I'd say, problems and challenges in their way. So my methodology, this is an exploratory study adopting a mixed method approach. Yes, I've been always a quantitative person, but here I added the qualitative side too. I applied a convenience sampling and snowballing technique. Data collection, I use an online questionnaire to collect information where I was able to collect data from 126 participants. And my qualitative, I had some structured in-depth interviews with 10 of the participants who filled in the online questionnaire. My study limitations, the convenience sampling and snowballing approach as usual, absence of up-to-date governmental policy notes on the management of HRH, and the limited evidence on the physician brain drain in Egypt. My research findings, let me go to the most important ones. For example, here I'll tell you that most of the participants were from Cairo, Alexandria, and Ain Shams. Maybe it's due to the sampling technique, or maybe it says something. The specialization, the highest representation is anesthesia and critical care. I know some hospitals at the moment are suffering from shortage of physicians in this specific department. So, for example, here, the highest degree attained in Egypt. So we have 50% who decided to migrate after they just got their bachelor degree. So they were not really ready to invest here. On the other hand, we have 11% who did their PhD in order to be able, who did their PhD and then they decided to migrate. So for the push factors, or in order to look at the push factors, first, let me tell you that almost 50% of my participants, they were working in university hospitals. These are the positions that usually students and medical students and physicians fight over. They compete. They try to get the highest grades in order to land this position. And then they leave this position to migrate. Think about this and let it sink in for a moment. So the main reasons behind the decision to migrate, the quantitative analysis showed the poor working conditions, economic factors in Egypt, poor quality of healthcare facilities as the three main reasons. On the other hand, the interviews, it gave us a bigger perspective of what's going on. So the results from the interviews, you could group the push factors into three main buckets. The first one is the professional push factors, where a doctor would leave due to the challenging work environment. Some doctor quoted that, well, I would ask for a radiological investigation and it's not there. I would ask for support from a nurse and the nurse is not there. How would they be able to work? Lack of quality educational and training programs. On the other hand, the financial push factors, the need to fund marriage expenses. So someone said that I cannot ask my family to support me. I cannot ask my family to support me financially, especially that they funded my education. I understand that this could be tricky for some people, but this is the situation. Depending on parents' support while working 60 hours a week. Yeah, you cannot be 30, 35 years old and ask your father or mother to foot your bills, especially if you're working and you're working a lot. Economic and socio-political push factors, crushed hopes. A lot of people experienced this, specifically after the Arab Spring. And it was a way to escape devaluation and the ongoing economic crisis. So 72 of the participants in the study, they were in their first choice of a country. So this tells you how good the Egyptian physicians are. You decide to go to a country and then you go. There is no problem. Yeah, you pass through the process. Sometimes it's a tricky process. Sometimes it makes you work a lot for it, but you land your first choice. The main reasons behind the decision to migrate to this specific country, high quality of healthcare facilities, available of educational and training opportunities, high quality of life and living conditions. This is from the quantitative side. From the qualitative side, you can easily put it in two buckets. The first one is the professional pull factors, high quality training and educational system. They are seeking high and better qualities of training. The second is the strong health system. They would like to work in a strong health system that does not hinder their profession as physicians. On the other hand, there are financial pull factors like the generous benefit package with a guaranteed time off And in order to accumulate savings, for example, my interviewee, who was based in Saudi Arabia, she said that she was there in order to accumulate savings to be able to go to UK. So Saudi Arabia for her was just a transit country. And she was just accumulating savings to be able to afford to go to the UK. So facilitators of migration. What helps physicians to migrate? It's the social network of friends and colleagues in the country of choice, success stories of fellow physicians, and social media platforms. Most of the time, social media helps. And from the interviews, yes. So the two main facilitators are social media networks, specifically Facebook and LinkedIn, and networks of friends. You usually contact your friend. If you are an Egyptian physician, you definitely have at least one friend in any country you would like to go to. So barriers and challenges, mainly cultural barriers, legal norms regulating medical practice in the new country, behavior of some co-workers that could be perceived as stigma, or it is stigma for real. So the main barriers are brain waste. So you are working as a physician here, you have your license, you're treating patients, but you go to the United States of America, they tell you you have to repeat your residency again. This is brain waste, like you're redoing your work again. Unequal opportunities. Some countries like Saudi Arabia, if you are applying for a promotion and then there's a Saudi person applying for a promotion, you usually don't get this promotion. And it was said in the interviews. Structural racism, yeah. Well, racism from the patients, racism from your colleagues, and racism from your bosses, which was evident in the interviews too. Conclusion and recommendations. So in most cases, the decision to leave Egypt was already taken, regardless of where they are going to go. The repelling power of the push factor of what's going on in Egypt was perceived much more strongly than the attracting power of any other high-income country that attracted the physicians. Based on the pull factors, we have two main groups. The first group includes the European countries and North America, where the professional pull factor was the bigger factor here. On the other hand, Gulf countries, it's the financial pull factor that played the role. During the migration journey, physicians, they encounter a lot of problems. They have to make decisions. They have to sit for exams, even repeat exams, learn languages, yet they do that. Think about it this way. Regardless of how much effort they need to do, they still do it. So my recommendations, start by reforming medical training program, revise the residency program, enhance clinical training, promote research, capitalize on the returning physicians. Some of them come back, facilitate the return, facilitate their integration in the system and how they can work and help your healthcare system. Knowledge sharing. For future research, we need to talk to decision makers in the language they understand best. Tell them the economic impact. Tell them how much it costs them to lose one physician. The specialty-specific studies, as I mentioned earlier, some specialties are suffering more than others. Updated nationwide database. Believe it or not, there is no nationwide database that tells you how many physicians in each specialty or in each governorate or whatever. These numbers are in the medical syndicate, but they are not updated and it's not detailed or disaggregated. Evaluate your policies. If you have a database, you will be able to evaluate your policies and look at your trends and monitor them. And improve the benefit package. You need to offer competitive salaries as a policymaker, and you can look at the non-monetary incentives too, but competitive salaries are important. Thank you.
Thank you so much, Dr. Mannatullah. It's quite a rich study. You put a lot of useful information, and I'm sure that policymakers who are tackling this issue nowadays, and now it's brought to the attention of at the highest policy levels, because investing in health and education, as we all know, is a top priority for the government. I think we all enjoyed the 4 presentations, which were very well made, very well presented, very rich in terms of content and presentation as well. So I enjoyed it very much. Now we open the discussion. the floor for discussion. If you want to have any kind of question or observations, yeah, please do. Yeah. Yeah. If you can just present yourself and then ask the question, please.
Okay, I'm Hamad Abdelawati. I'm a clinical pharmacist at Cairo University Hospital, Emergency Hospital, Australiani. I'm a master student biotechnology at EUC. So my first question is there any specific age group you made your study?
No, there was no specific age group, but my participants, their age ranged between 30 and 39, and I can attribute this easily to the sampling technique I applied because it was convenience sampling and snowballing. So they were mainly my colleagues and my friends who are residing abroad. I sent them the questionnaire and they promoted the questionnaire among their networks. It would have been very tricky to target a specific age group without the listserv of alumni in universities. Universities, they don't have like a database for their alumni, and I cannot reach out to them, for example. And even if they have, there will be the data protection policies.
I asking that because I found it is interesting now that students of medical students, even now, they don't compete for residency. They planning to travel and migrate even before graduation. So they trying to take this exams and prepare before.
Yes,
Taking
almost 50% of the participants, they left the country after their bachelor degree only.
Yeah.
So they just graduated and they left. While like 15, 20 years ago, I would tell you that people would still get their master's degree first. So yeah.
But if I may allow me to add on this, actually, the crisis, what Dr. Minutullah, which is in the literature also very well recognized, the human resources for health crisis. This is a global crisis, and it's now highlighted as the mental health issue. Now this is also another global health issue, and for the global health policy, actually, this is one of the main challenges for policymakers, and it's not only happening in Egypt. Many other countries. In India, you will find it, in Bangladesh, for example, in Pakistan, and probably these countries that I named specifically, I lived in UK for some time, and there were, the areas where I lived in, it happened, that we have my GP was an Indian doctor, and they are perfect, they are very good people, and they are very clever, but I mean, it's a global issue. So now we have to put it in the context as well. So,
and the problem is not with physician. Actually, it's in all healthcare providers, nurses,
exactly.
and pharmacists.
Yeah, that's true. That's true.
Okay, my second question
sure.
to Dr. Marwa.
Yeah.
Why in your policy recommendation you recommended for government to invest more? Actually, as far as I understand, Qatar is a rich country. They already provide a lot of money, and investing 2%. And the problem was socioeconomic factor, not in money or not in the coverage of health.
Okay, it's both. The problem is when you go to Qatar, the health facilities are really nice, right? Fancy, and then so it's what they're used to. So if you go to a health facility and it's all marble and it's very nice in their garden, and then you go to the mental health care facility and it's dark and there's corridor and everything's like old, and so then for them, like for us, like for people from Egypt and Tunis we interviewed, they were happy. They were like, nice facility. But for them, for the Qataris, they're still seeing a big difference between the standards that they see in the facilities. And also, if they want to be consistent with other high-income countries, they devote around 5% for mental health, and they only devote like 2%. So it was kind of, so it came up in the interviews as a problem. But of course, the more pressing issue was like the stigma, the limited awareness. That was a more of a bigger issue.
For this issue, what's your policy recommendation for the?
My policy, so our policy recommendations in the paper were for increasing awareness, their models, like in Canada, in Kuwait even, there is like somebody from the royal family who took a really active role in saying mental health is nothing to be ashamed of. She said, I suffered from depression for that long and anxiety. And then when people do that at that level, like some of them were telling me, if the Emir of Qatar came out and said that he thinks mental health is something that should not be treated as stigma, then that would change a lot of minds, or Sheikh Ahmed. So they really need to feel that to normal, like that mental illness, we all suffer from it at some point in our lives. So why not talk about it and not treat it as something? So they had a lot of suggestions. I didn't have a chance to go about how to like deal with the stigma and the awareness. And yeah, thank you for the question.
I have more questions. Yeah, I just have one more. What is a semi-structured interview you mentioned in your research? How?
Semi-structured was that the outline of what needs to be questioned was there, but again, as the interviews
Put it closer.
closer, thank you. As the interviews deployed, depending on the answers, more deeper questions were
So you're changing the
yeah.
questions as
Yeah.
far as you go.
not changing, but going into more details depending on what the answer were, so as to extract the real meaning of what they wanted to say, sometimes behind the words.
Okay, so is it better than going with the specific questions?
Yeah, because it allows them to speak more. For example, when you talk to physicians, they usually push back. They say, we do a very good job. They're reluctant, saying, we are missing this part. For example, in the study came out that, they don't have the data, they don't measure survivability. So how do you know if your treatment was effective or not? You don't know if the patient is alive, how long they lived, if they came back with recurrence. They say, the file closes with the oncologist. If the patient dies, the oncologist signs the file and it goes there. So those specialties before the oncologist don't know how well they performed because they don't have visibility on the survivability of the patient or, the quality of life she had. She leaves from their office, from their specialty, case closed for them.
More questions from
I
the
have
floor?
two questions.
Okay, if we can finish the floor first, and then we can ask ourselves. Please go ahead.
I'm gonna ask Aya the question. First of all, لا 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 قشطة. I'm Judy Hamdi. I'm a technical officer at the chairman's office of Egypt Healthcare Authority, which is the healthcare provider of the universal health insurance project in Egypt. So I have a question. While telemedicine is the perfect solution to bridge the gap in healthcare access in rural and underprivileged communities, does the strategy of the telemedicine by Gohar or the national standards, I have no idea, يعني, does it address the rate of technological illiteracy in these underprivileged areas? Because as far as I know, these people don't use smartphones as much as we do, and they don't use the social media platforms, or they just don't use technology as much. So how are we gonna address this issue? Okay, that's the question.
Thank you, Judy. There is two things. If digital health strategy for the digital health at all, not telemedicine specifically. And there is a standard for telemedicine in hospital accreditation standard. For telemedicine in hospital, they must have a policy for telemedicine operational and privacy. Okay. About rural area, I did telemedicine in breast cancer patient in previous hospital I worked for, and they were in a rural area, and this was our first time to do telemedicine. As an example, patient from rural area, they made a solution to have a mobile phone and to connect with us. I don't say it's a solution to make an substitution and found a solution to connect with your doctor, but in rural area in Egypt Healthcare Authority, they use a doctor to doctor telemedicine, not doctor to patient. I mean, doctor to doctor, the patient in rural area went to a primary health care unit and have a conversation with doctor, have the conversation with secondary or tertiary health care unit or doctors here in hospital, university hospitals, and connect with patient. And he told doctor how to deal with this patient, as this case must travel or not. I hope you answer.
Thank you.
Thank you.
It's part of the on-the-job training, if you put it that way, Yeah, sure. Any further question from the floor? Okay.
Is it applied already in any facility here in Egypt?
The universal health insurance facilities starting to implement. We have a virtual hospital. In Ain Shams University also, they have a unit for telemedicine. It's under the trial, but they serve many patients in rural areas, and they are experiences two things برضو final diagnosis and يعني first seeing for patient and plan implementation. They have the two categories, and they working in research. يعني I believe in research. I don't assume a patient in rural area can make it. Patient don't يعني don't complain about telemedicine. Doctor complain about telemedicine and payment method and underpayment, but patient don't. يعني in research patient don't complain about telemedicine, but يعني except it's found it a solution rather than traveling and expending money and effort to travel to another يعني city. Thank you.
Include any about independent pharmacies. I was reading.
Yes, it's all healthcare providers, even quality specialists and administration working in healthcare facilities. It's for every healthcare provider.
It's work also.
Yes.
Digital health is becoming an area of further expansion very much in the coming years, along with the artificial intelligence and the design thinking. So it's really, yeah, exactly. No. So we touched based actually today on many important areas for further innovations in the sector. Yeah, please, doctor. Yeah, sure, please.
Yeah, to Dr. Marwa. Following on the comment of my colleague Mohammed, I was astonished throughout your presentation that the healthcare facilities, mental health care facilities in Qatar are suffering bad condition, bad experiences. And at the same time, it is a rich country. And overall, Qatar is one of the countries in the Gulf where the quality of living is very good, and it's a very good country. I understand that the style or the model of the research is phenomenological, so you are capturing or focusing only on the experience of the patient. But did you encounter capturing the feedback from the healthcare providers, other stakeholders that may put their input in drawing a bigger picture helps to better understand the situation?
Yeah, that's an excellent question. So our focus was on basically clients, patients who are receiving the care, and understanding their perspective exclusively of the care they received. Basically what tells you that objectively speaking, the quality of facilities is quite good is that when we have people who are, so we interviewed Qataris and non-Qataris. The non-Qataris thought that the facilities were great. So it's all relative. It's only perceived.
Perception.
It's about perception. And it's like it is because the other facilities are so nice. You know what I mean? And so it's perceived, and if it's perceived for them that is depressing, that is dark, then it's like it's important because it's real to them. You know what I mean? Even if objectively speaking, I go and you can really tell by looking at the non-Qataris that we interviewed and how they think it's great. You know, like it's great. So yeah, it's relative, and I think it's an excellent question, because like if we were to do follow-up before we do any kind of like more quantitative analysis, then the perspectives of administrators and healthcare providers should also be understood. But to be fair, like this study was really about you know how in policy you have like the people, the recipients, the clients. So it was about understanding their perspective on the service. But thank you for the question.
Thank you very much. My other question is to Minna. Sorry. So Minna, you mentioned that most of the physicians that participated in the questionnaire, they got accepted in the first country they chose or decided to go to. Was it their first country or was it UK? Because I know that UK is a very special situation for Egyptian doctors. So there are like migration campaigns to the United Kingdom, and the United Kingdom is opening a door for absorbing a lot of physicians. I'm not sure. I did not do a lot of research in this regard, so I'm not sure is it only from Egypt or from everywhere else. But almost all the physicians I know in my family, in my friend, they all went to UK. So was it UK or was it the first country of choice? Thank you.
Thank you very much for your question. So 48% of my participants were based in UK. This is 48%. But then on the other hand, 72% of all participants, they said that they are based in their first country of choice. They didn't have to settle for a second best. So, and this includes, usually this would include people in the UK, would include people in the USA. I would tell you something that was not shared here, but it's in the bigger thesis, that most of those who said that they had to settle for a second best, they were targeting USA. But the thing is, if you need to get your license again, you will have to sit for rigorous examinations. You will have to repeat your residency, regardless of who you are in your country. Even if you are the Minister of Health, like you will have to redo your residency all over again. Even sometimes you'll have to do your internship here. So yes, I can say that some of them are based in UK. But we have Egyptian physicians in Germany. They go into the hassle of learning German, even after graduation, when you're like 23 or 24-year-old, and like it's very difficult to learn a new language. You learn it and then you go to Germany. So like the situation is the situation is a little bit catastrophic here. And yeah, sometimes you cannot land USA, you go to UK, or you cannot land UK, you go to Gulf country to get more money so you can go. But yeah.
And to put it in context, if you look at demographic changes happening in Europe particularly, you will find that many countries are deprived of human resources in various areas, not only in health. But in health particularly, the NHS in UK is suffering, especially after the Brexit, because they lost many of the other European countries' health professionals, and also in Germany, because of the demographic change happening there. So it's becoming a global phenomenon now, not only affecting Egypt, as you mentioned earlier. You finished with your questions? I think you had a question, and then we conclude, and then Dr. Jenny will have last questions. Please, yeah.
Okay, thank you for the amazing presentations. So my first question for Ms. Aya. So, Aya, do you think that we need to act the medical liability law first to implement the telemedical efficiency? And the second question for Dr. Jenny. So, according to the study, you mentioned that there is many women, they already will knowledge, or they have already awareness about the breast cancer, but is that include the women in rural areas or in marginalized places, or like who are those women that they have this knowledge? Thank you.
Thank you for your question about law of telemedicine. Under preparation now in Egyptian Parliament, there is a law of telemedicine, but we have a telemedicine solution or a telemedicine initiative in Egypt, even in governmental sector. So they are working behind أو يعني in parallel to the law of telemedicine. But you are right, we have to wait to implement the law of telemedicine, then we go for strategy and standards. But we now have a e-health strategy. يعني it's implemented but not in public, so we have a draft only, like I showed. Yes. يس زي ما بتقولي، هو ما فيش فعلا القانون المصري ما فيش فيه جزئيه التلي ميديسن، والقانون واضح ان هو الطبيب يباشر المريض، فهو لازم يعني هو فيس تو فيس، هو ما فيش في نص القانون حاجه للتلي ميديسن. بس هو دلوقتي في انيشيتيف موجوده، فاحنا مش هننكرها، يعني احنا لازم نقننها او ان هي تكون تحت عباءه يعني ليجلي، ان هي تكون موجوده، او ان احنا نكون منظمين ده، يعني في استراتيجي في ستاندر الى ان يصدر القانون. بس القانون القانون فيه جلسات ليه كتير يعني اوريدي شاركت في كذا حاجه ليها، وشاركت برضو في الاستراتيجي بتاعه الاي هيلث، بس هي متوقفه ان احنا ان يعني كان المفروض تصدر في مؤتمر الصحه اللي فات في يعني في وثيقه الصحه المصريه الجديده، بس هي ما اصدرتش للسبب اللي قلتيه مظبوط. يعني هي اتاخرت لحد ما يصدر القانون، بعدها تبقى موجوده الديجيتال هيلث استراتيجي. شكرا لسؤالك، حلو قوي.
طيب شكرا. So to your question, what I said, they have awareness of the screening programs, and the 100 Million Lives initiative has vans that go around to the rural areas. That's why they know they get screened, but they don't show up for treatment. That's why they are advanced in their awareness of screening, because they're mobile vans that run around the country. Yeah.
Okay. Now, last question. Yes, please. No. Yeah. Press the button.
Okay,
yes.
now it's working. Okay, so my name is Noura. I'm a pharmacist originally. I work in CSR in and Egypt. So my question is for Aya about telemedicine. So I just wanted to ask about the context of telemedicine in Egypt now, its abundance. Is it does it have high prevalence in the private sector, NGOs? Is it really serving underprivileged areas? How do you see it serving these communities specifically?
Thank you. There is initiative of يعني telemedicine, private health sector providing telemedicine service in hospital, and also NGO, which I was working. It was an NGO hospital delivering telemedicine for patient who can come to the hospital. Anyone, not even for rural, even in the Great Cairo, they use telemedicine. So it's implemented. Many hospitals implemented telemedicine.
Okay, now I think we have to come to a conclusion now because we are 15 minutes late. Yeah. 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 But Dr. Jenny asked, yeah.
Quick questions. Do you know the roadmap for Europeans is like, the Austrians go to Germany for more money, the Germans go to the UK for more money, and the UK physicians go to the US. That's the roadmap. Do you have comparative data, like there are more Egyptians migrating than, for example, Germans going to the UK? You don't have, if you have this information just out of curiosity, which it's not easy to collect.
So I don't think there's a study that did that, but then so you can say that physicians are usually, or anyone is going after a better opportunity. But if, for example, 5% of your physicians or 10% of your physicians, they migrate to a country, it's different than when you say 56%.
Yeah, true. I'm just saying if there is comparative data.
Yeah, so even in the burden of migration, this is the only available data. So when you look at Germany, yeah, I think the last number I said, they said 7% or 9% of their registered physicians are not working in the mainland, like in Germany. But you compare it to 56%, it's nothing.
Huge.
So yeah.
And one last one. What's the prevalence of mental problems in Qatar?
So the recent studies in the mental health strategies, they only talk about the gap. So I have the statistics, but in terms of prevalence of specific diseases, you have no. It exists according to estimates from WHO, but it's yeah. We have to.
Quantitative.
Yeah, we should do another quantitative study examine.
Having said that, we need more studies, follow-on studies, because I think you tackled 4 important areas, a lot of innovations, a lot of aspiration, a lot of needs for further research. Thank you so much, Dr. Aya, Dr. Jani, Dr. Marwa, and Dr. Minnatullah. We enjoyed very much your presentations. And now we will come to a moment that I think we have to give a big applause to them because of what they did. And now we can hand them also certificates. So let me, Dr. Aya, thank you so much. Thank you. Yes, please. Yeah, please. Yeah. Yes. Yeah, sure. Sure. Yeah, sure. Okay. Thank you so much. Very well done. Okay. Dr. Jenny. Thank you so much. Yes.
Thank you.
Thank you so much.
Thank you.
All the best. Yeah. Yeah. Yeah.
Sorry.
Yeah.
Yes.
Okay.
Thank you.
Thank you. Dr. Marwa. Thank you so much. Okay. And Dr. Minnatullah. Sorry. Thank you so much. Thank you so much. We have Dr. Fatima. Dr. Marwa, are you going to see Fatima? Yeah, please. Okay. Then we can take a group photo, Dr. Jenny and Dr. Aya. Yes.
We need to hold this.
Yeah, please.
Will we see the photos anywhere?
Yeah,
Will that
I
load?
think we should be receiving, we'll be receiving the photos, I think. All colleagues. Okay.
Yeah, they will send us instructions.
They will send it to everybody. Okay.
Can we take a picture with you?
Yeah, sure. Be an honor.
فيديو ممكن ايوه ما انا عايزه كده انا